afterwards. I'd also like to warmly welcome our guests today, who I'll shortly introduce. And today's webinar is titled Pharmacy Practice in Long-Term and Aged Care. This is the last of 3 webinars that FIP is hosting throughout October as part of the series, The Role of Pharmacists in the Care of Older Persons. I'd also like to acknowledge that today, the 29th of October, is the International Day of Care and Support, as declared by the United Nations. This day highlights the importance of care and support to all those who are dependent and recognizes the essential role of caregivers and care workers. It encourages stakeholders to take action to protect the rights of those receiving care and those providing it, a message that resonates strongly with the focus of today's webinar. Several global organizations, including the World Health Organization and also the United Nations, have urged countries to develop long-term care systems to respond to the aging population. So we know that while long-term care is not exclusively for older adults, most recipients are indeed older people. With multimorbidity and polypharmacy increasing with age and dependency, medicines are among the most frequently used therapies in long-term care. And this is, of course, an important reason that makes pharmacists essential professionals in long-term and aged care, supporting safe and effective medication use for those with complex needs. So after this long speech, I would like to briefly introduce myself. So my name is Filipa Alves da Costa. I am the Vice President of the Social and Administrative Pharmacy section at FIP, known as SAPS. And I'm also an assistant professor with tenure at the Faculty of Pharmacy, University of Lisbon. As you can see on the slide, we have some announcements to make. So please note that this event will be recorded, live streamed on FIP YouTube, and the recording will be available at events.fip.org. And to all of those listening, please feel free to send your questions using the Q&A box at the bottom of the screen. And I'll do my best to manage all the questions so that at the end, we will be able to address those questions with the contribution, of course, of our fabulous panel of speakers. You're also welcome to provide feedback to webinars@fip.org. And I would like to take this opportunity to promote the benefits of membership with FIP, including events and webinars. FIP is the global body representing over 5.5 million pharmacists and pharmaceutical scientists. And so if you're a pharmacist or pharmaceutical scientist and you would like to become a member, please register on FIP's website at fip.org. For those of you that are not as comfortable with English, you will have the possibility to turn on the captions and enable the translation toggle. You can choose your preferred language under My Caption language, and now you can follow along with live translated captions. So for this event, we are joined by a panel of fabulous speakers, and I wanted to sincerely thank each of them for taking the time to prepare their presentations. So for our program today, we have the welcome and introduction, which I have just finalized, and then we will have our first speaker, Professor Cheryl Sadowski, who will be talking about research and pharmacy practice in geriatrics. We then go to our second speaker, who will talk about the value of integration and interprofessional work in long-term care and aged care. And then we will finalize by our third speaker talking about pharmacy practice in long-term care and aged care, talking about the national case, in this case in Portugal. And finally, we will have a moment for some questions and answers and wrap up by our speakers. So for today, we have some learning objectives, and these are to outline the fundamental concepts of long-term care and aged care. We expect participants at the end of the webinar to be able to understand the differences between social and health long-term care and the role of pharmacists, recognize the clinical profile of long-term care and aged care patients, appreciate the importance of interprofessional collaboration given the clinical and social complexity of long-term care recipients, and finally, describe and discuss examples of long-term care systems and pharmacy practice. So I will now present our first speaker, Professor Cheryl Sadowski. She's a pharmacist with a clinical practice in a geriatric outpatient clinic. She's also a professor at the University of Alberta, Canada, and she oversees the geriatrics curriculum at her faculty and also has research interests in pharmacist management of geriatric symptoms, deprescribing, and geriatrics education for pharmacy students. So thank you for joining, and the floor is yours.
Great, thank you so much. And thank you everyone for participating today. I do want to start off by noting I do not have any conflicts of interest to declare. I'm including my email on this slide, and it will be again available on the last slide and in the recording. So please feel free to reach out after if there's any issues you'd like to discuss further. I have a brief outline that sets us up for the rest of the presentations as well. So thinking about where are we in terms of data that we have, evidence we have for pharmacy practice, what evidence we have for what we can do. So when we are making a case for some of our work or thinking about expanding it, is it something novel? Is it something outside of what we already have evidence for, and how do we proceed with that? And then what's next, thinking about research priorities. So I hope I'm able to leave you with maybe more questions than answers, and that can get our discussion going. So this diagram on the right is a mapping activity that I saw in a recent article, and it's kind of a day in the life of geriatrics, isn't it? That we never have someone with just one condition and they don't have any dependencies. We see a lot of complexity, and in long-term care especially, we're seeing complexity is the norm. Multimorbidity is the norm. Polypharmacy is common, and dealing with appropriateness of medications is a challenge with almost every single patient that we see. One really interesting statistic that I came across recently is that is quoted about approximately 2% of any aging research is done in long-term care. So that means we don't even have enough research in geriatrics, and now only 2% of that really pertains to long-term care. So this is an area that is really understudied. The work is often, we know, undervalued, and so I'm really appreciative that we're having some time to talk about this specific sector today. And you can see some of the challenges listed here. There's workforce issues, but just the context for how complex our patients are really makes this a challenge. In my own setting, so I work in Canada, and we have, when we talk about intersections for how patients are vulnerable or our residents are vulnerable, people we are caring for. And so in some of our settings at long-term care, we have 3 out of 4 are female, but at least across Canada, 2 out of 3 are female, and the average age is at least 85 or older. We have many centenarians, super centenarians that we see in long-term care. So we're seeing an intersection of a largely female group of individuals who have a lot of complexity, medical complexity, often with dementia, and they're in a setting where they're not getting as much attention, research, or clinically as we would like to advocate for. We have, this is highly variable across countries, but I'm just taking a snapshot of what we have in Canada so I can speak from my own experience. About 1 in 4 take antipsychotics. We have about less than 15% rate of benzodiazepine use or sedative use, but a bit of variability, about 20% in my province for the number of individuals in long-term care on antipsychotic medications. In some cases, up to 80% have dementia, but again, variability. So your setting might be quite different. This is a few issues with trends, and I want you to think about in your own setting what's been happening over the last few years. So of course, we've had issues of COVID, which have disproportionately affected how we've delivered care and harmed many of our residents in long-term care. In Canada, we saw an increase in antipsychotic use, and that has not gone down. It went up and plateaued, unfortunately, even though we are not past having COVID, but dealing with some of the pandemic issues. Falls were just over 15% and have remained about that, even with our increased antipsychotic use. So I'm just highlighting a few statistics that might pertain, as you would think, to pharmacy practice. And then pain. This is a marker that sometimes we think of as an interprofessional marker of success or quality of care. And yet this is something where you'll see some of the evidence I'm presenting a bit later really highlights pain as a marker for showing how pharmacists might be improving care. And what's interesting is we see some declines here. So maybe we were a bit more assertive or liberal with using some of the analgesics or thinking about other approaches to pain management over the last number of years. When we start to get into the research activities, we have actually quite a few different studies talking about how pharmacists work in long-term care. We have 2 systematic reviews I'm going to be presenting here, and this was published a few years ago, 6 years ago, but even up to that point, they have over 40 different articles in here. We don't have quite as many randomized controlled trials. That's harder to do when you're looking at the setting that we're in, but just looking at, in some cases, pre-post results. And what's interesting here is looking at different outcomes. So as you do a systematic review, you might specify ahead of time which outcomes you're looking for, but then you're also looking at the articles themselves, what was reported. And so what's interesting is mortality is frequently reported. And in this case, there was not a benefit, not a statistically significant benefit to having pharmacists involved. So I'll plant the seed there. If you think that's an appropriate outcome we should be measuring for pharmacy practice going forward. When we look at numbers of falls in this particular study, and again, there was many other outcomes. For time, I won't go into all of them, but looking at number of falls, this is something where they did have benefits. So pharmacist involvement in medication reviews, engaging in team activities, education, etc. They did find that pharmacists, individuals that had a pharmacist intervention did have lower incidence of falls. And medication appropriateness index, we're all used to different measures of medication appropriateness, medication, high-risk medications, PIMS. And so MAI is one tool that is used. And so after a pharmacist handles the medications, does a review, usually the MAI or the appropriateness of medication overall on that regimen will improve. This is another review. So this is one that I was involved with. And we have some different articles here. We were looking more at the roles of pharmacists. So some similar work, but a slightly different research questions. And here we were looking also at system outcomes. If having a pharmacist do some assessments and reviews and interventions in long-term care, if that impacted the system. So were less individuals from long-term care triaged and sent to hospital. And it seems like there's a trend, so it's still touching unity there. But that's an interesting one when we think about what sort of outcomes do you think your work has impact on? And if you were doing research, what outcomes would you design into your studies? What's meaningful to the system, to policymakers, to clinicians, to the people that we're caring for. And then also we reported on mortality here. So pharmacists do not seem to reduce mortality in long-term care. I'll point out in the province I work in, life expectancy is 18 months once someone is admitted to a long-term care facility. A couple of other articles I want to bring to your attention relate to reviews that are focused on how to improve medications. And so this is not agnostic of which professional, but in many cases, this is pharmacists providing these interventions. But the focus is on, the authors really want to make a point. Other professionals can do some of this work as well, nurses, physicians, others. really trying to improve medication use and safety and decrease harm, improve outcomes for older adults. And so they highlight things like medication reviews. Yes, we know that that's important for pharmacy, but in the articles, I'll just point out, they just say medication reviews should be done. They don't suggest which specific professionals. So for purposes of our presentation here, I think we could say pharmacists could certainly step up and do this, and we've been doing it quite well. In terms of case or team conferencing, that's important for pharmacists to be involved, thinking about communication, thinking about priorities, other aspects that you don't glean just from the chart or looking at medications. And then I'll talk a bit further about technology and education. Obviously, much of this from the Cochrane Review highlights team building or relationship building activities in the facilities. And then Anne Spinwin from Belgium and colleagues have written a narrative review on optimizing medications, and it includes things like really a focus on particular medications. So general medication reviews, we have evidence already seem to improve some outcomes, such as reducing falls, improving metrics like medication appropriateness. But if we really want to lead to deprescribing or reducing harm and harder outcomes, perhaps we could see with, say, with antipsychotics, the hypothesis is maybe that would lead to reduced mortality because they are associated with increased risk of mortality. So really targeting with our medication reviews, particular classes of medications and priorities, and dealing with documentation on transfer, which partly is a technology issue as well. Now, I'll point out this was a review in BMJ Quality and Safety, and they've highlighted technology as their number one solution. Even yesterday, I was giving a presentation to a group, and the number one solution people wanted to know about was, and how is technology helping older adults? This is a map, and it's meant to be a very busy graphic because it's complex. This is some work that we did at a long-term care facility with one of my graduate student, Andrew Fuller, nearby our university. And, really a lot of beds, a lot of staff, a lot of levels of staff, some with very basic training, healthcare aides, all the way up to managers. And we tried to map out everything that was happening with some of the technology and handling the medications. So we had barcode technology, scanning, electronic health records, wristbands on patients, and really trying to map out all of those different touch points and all of the complexity with all of the people and the touch points involved, and then the complexity of the different products that are used. So there's inhalers, there's patches, liquids, etc. And so, there's really a lot of considerations. And so when you map that out, I do feel pharmacists are some of the few that really can understand the map from beginning to end. And so this just highlights there's a lot of opportunity for technology, but we also found in this particular research there was a lot of workarounds and people were frustrated with the technology. So really understanding what that map looks like to you, where those touch points are, and having relationships with the staff and managers so you can figure out how you can fix or prevent some of those workarounds. What I found interesting as I was preparing for this, what AI tells us, what the composite of the World Wide Web has to say about what pharmacists can do in long-term care. And for the most part, I think it's fairly accurate, but I will point out, I'd like to, instead of the third term there, team collaboration, education, thinking about relationship building in the settings that we're in. So we're getting a good understanding of what the needs are for the staff and the residents there as well. And then I also think leadership and policy leadership are missing. It's important, and we have other experts on the panel that can talk to this as well, but thinking about how others are perceiving us, if they just think we fit into doing medication reviews, and we're underutilized in terms of, say, mapping the technology or thinking about opportunities with education, they're going to, we could inadvertently be sidelined. So thinking about where we need to step up in advocating and encouraging use of our expertise to be strategic, I think, is important. So these are a few of the pending questions I think we have, like what's the best use of our expertise. I think there's lots of areas where we can contribute to, but just doing medication reviews is not the only solution. And so I think these are where some of the points where we're going to see some results coming out. There's an Australian study I'll point out, for instance, called, the acronym is PharmaCare. You can see that there. They're still developing or gathering some information. They've developed a framework for different metrics in Australia that they can measure for. And so I think that's a country that is really leading in terms of pharmacy practice. It's driven by policy and thinking about reimbursement. But in the meantime, I think the evidence still encourages us to keep, really doing a great job with our medication reviews, but probably targeting a little bit more, having a bit more tailoring to what's needed in that situation, and thinking about relationship and participation. I think that's sometimes we call soft skills, but often undervalued. And then finally, thinking about leadership and thinking a bit outside the box for all that we can provide in terms of stepping up when there's technology opportunities and understanding the care needs in those settings. So I hope I've left you with a few questions, and I will hand it off, and hopefully some of my panel members are able to give you some answers there as well. Thank you.
Thank you very much for this fascinating presentation, and also for some of the provocative questions that you have left participants with. Some of them have already left questions in the Q&A, so I just wanted to remind all others to please use the Q&A box so that we can discuss these issues such as outcomes and role of the pharmacists at the end. So I'll now pass on to our next speaker, Dr. Niamh Lennox-Chhugani. She's a chief executive of the International Foundation for Integrated Care. With her background as a clinician, academic, and consultant, she's an integrated care researcher and implementer in an international context. She's a regular speaker at conferences, on panels, has authored peer-reviewed papers and book chapters, led and contributed to health system reviews and integrated care evaluations globally. She has a PhD from Imperial College of London in Organization Change in Healthcare, and she's also on the editorial board of the International Journal of Integrated Care and sits on the advisory board of numerous integrated care research programs. So with no further ado, I'll pass on to Niamh. Thank you. The floor is yours.
Thank you very much, Filipa, and thank you very much to the team for inviting me to participate in this webinar. I'm going to make a full disclaimer here. I am not a pharmacist, so the perspective that I'm going to bring this morning is around integrated care and integrated long-term care, and what the role of different professionals, including pharmacists, can and should be in the context of integrated long-term care. And there was so much in what Cheryl just presented that I think resonated for me in her presentation. And I'm going to probably draw on some of the themes and some of the questions that Cheryl raised as I go through my presentation. But just very quickly, for those of you who don't know who the International Foundation for Integrated Care is, we are a not-for-profit knowledge organization that really is devoted to promoting integrated care practice globally, so that we will get to a point where people and communities experience seamless care across health, but also across social care and other parts of our systems. We're not a member organization, so anybody is welcome to join in the conversation and the movement for change. We've been around since 2000, and we host a journal as well as an annual international conference on integrated care. So what I'm going to start with really is just by defining integrated care. Now, I'm going to focus on integrated care as a shorthand, but that includes integrated long-term care. And when we at the Foundation talk about integrated care, including integrated long-term care, we don't have a single definition. what we do say is actually you can have quite narrow definitions that are focused on joining up or coordinating services within a health system, and that could be just a private healthcare system in a particular geography, but it can also be as broad as integrating health and social care and housing and public health across a whole spectrum of population health. So the important thing here is context. It's about a country's path to health and care system development and what is appropriate and prioritized from a policy and practice perspective in that country at any given time. What we do say, though, is there are some core features of integrated long-term care, and a good way of defining this is by answering a why, what, and how set of questions. So why do we do integrated care? Well, it's strongly linked to the quadruple aim. I'm going to come back to this in a moment to demonstrate how integrated long-term care can help us deliver on the quadruple aim, but that's really why we do and advocate integrated long-term care. Well, what are the core features? Well, we say that the core features of integrated care, including long-term care, is that it is people and community driven. So it's based on what people and the community in which they live need and want. And it's about coordination over different settings. And it's about continuity and experience of continuity over time that might be across a whole lifetime. And at the foundation, based on 25 years of research and applied research in practice, we've identified that there are 9 conditions or pillars of integrated care. So these are the conditions that need to be in place in any system in order for integrated care to be delivered. If we think about how we make integrated care a reality in our health and care workforce, and that includes pharmacists, we can think about it in terms of a theory of change for integrated care. And if we look at the context that we know for our health and care workforce, and that very much includes pharmacists today, we have a health and care workforce crisis today, and we recognize that. And one of the responses to that crisis has been the integration, the structural and functional integration of our systems. So we've been reorganizing our systems to integrate them better, to reduce the silos in care. And I think Cheryl talked a little bit about those silos and how they can contribute to some of the clinical risks that we see in our populations, particularly older people. But also it means a move, a shift to interdisciplinary working and recognizing the importance of including people and caregivers, older people particularly, and their caregivers in that interdisciplinary team. And that's where we start to look at relational care in a context of integrated long-term care. And I think Cheryl talked about the importance of relationships and building relationships. And we talk about that in terms of relational care in integrated care. And then the outcome is a better experience of care for people, for communities, and for staff. So do we know? What do we know about whether it works or not? Well, we know we have a number of systematic reviews that have been conducted over the last 10 years that show that integrated care has positive effects. We also have condition-specific evidence that integrated care works. There was an umbrella review that was conducted by colleagues in Portugal just a couple of years ago, and it looked at the quadruple aim and whether we were delivering, by delivering integrated care, we were delivering on the quadruple aim. And it did show that, in fact, we do have a positive effect. We see a positive effect on people's experience of care. We see better clinical outcomes for people, both condition-specific and population experience of care. We do see better value for money. So we see cost savings, particularly in terms of reducing hospitalization for people. And we also, but this is not sufficiently researched, we do need to build up much more of an evidence base around this, but we do see higher levels of satisfaction for professionals working in this way. So just very quickly, looking at pharmacy specifically, we do have quite a body of research that looks specifically at the role of pharmacists in general practice, so in primary care, and the positive impact that including the pharmacist within an interdisciplinary team within primary care can have. And again, I think Cheryl touched on this. We do see a significant emphasis on the role of the pharmacist in terms of reducing medication-related hospitalizations. But one thing to bear in mind, a 2019 review, whilst it reinforced the point about the improvement in clinical outcomes stemming from pharmacists' involvement in an integrated model of primary care, that whether that led to an impact at system level is less clear. And whilst again, the effect on the immediate general practice that they're involved in is clear, it's whether they in fact may be contributing to an increase in primary care activity. And that may well be because they're helping to identify previously unmet need. So that is obviously an implication for policymakers to consider. But nonetheless, I think it's clear, as with all models of integrated care, having pharmacists included as an integral member of a primary care team overall has positive effects. So I'm going to focus just on 2 countries and their experience. One is Flanders, which is a very good example of a country to look at in terms of their journey to integrated care. It has been going on now for about 15 years. It started off very much in community care. Over the last few years has included primary care more proactively, and now is starting to shift to including hospital care in their model of care. But certainly in primary care, pharmacists have taken a very active role in making integrated care a reality in the region of Flanders. Ireland has been on a similar journey. I think pharmacists have perhaps been less central up to now in the delivery of integrated care. I'd be very interested in the views and thoughts if we have anybody attending today from Ireland on their views about the contribution and some of maybe the constraints to the contribution of pharmacists in making integrated care a reality in Ireland. One of the challenges there is there has probably been less focus on engaging with primary care around integrated care up to now. And only now really are they focusing in Ireland on integrated long-term care. Although interestingly, they are taking a much broader population perspective on that through initiatives like the Age-Friendly Ireland initiatives, which are very much following the WHO Age-Friendly Cities and Communities program. So if we think about what the key mechanisms are for delivering integration, Cheryl touched on the importance of integrated information, but I'm going to focus more on interdisciplinary team working and co-producing care with people who are in receipt of care is one of the other really important mechanisms. But if we look at the interdisciplinary team, I think one of the key things is the differentiation between interdisciplinary teamwork and multidisciplinary teamwork and interprofessional collaboration. So interdisciplinary teamwork is not just interprofessional, because it includes people at the center of care and non-professionals within the team. And especially when you're delivering long-term care, those people are absolutely essential to be involved and full members of the team. And it's also a bit different from multidisciplinary teamwork, in that often multidisciplinary teamwork involves people remaining within their disciplinary silos and only coming together to complete specific tasks together. Interdisciplinary teamwork is much more about a shared purpose and building an interdisciplinary team that creates new interdisciplinary knowledge. And it does that by having team goals, by sharing and understanding each other's different roles and responsibilities, and creating an interdependence because of that. And then they create a new identity, a shared commitment, and start to integrate work practices. But this takes time, and it takes very conscious interdisciplinary team leadership. And it means developing a new set of competencies, which it is behoven on our professional organizations and our educational institutions to really start equipping our different professions with. And just in terms of the kind of special interest groups that we host at the International Foundation for Integrated Care, which some of you may consider joining, we do have a polypharmacy and adherence in integrated care special interest group. We also have an integrated long-term care special interest group. And you might be interested in following the work of one of our European Commission funded projects, the Laurel project, which is building the research and evidence base in integrated long-term care practice across the European countries. So please do follow the work of Laurel and do get involved in some of Laurel's activities, which include webinars itself. And I think they would be really keen to hear from the pharmacy profession on how to promote integrated long-term care. And just a quick note, we have a conference next year. The call for papers closes on Sunday, but if any of you have integrated long-term care experiences you'd like to share, please do think about submitting an abstract. Thank you very much for listening.
So thanks, Niamh. It was extremely interesting to see like a different approach, and I must confess I'm finding it a bit tiring to listen to pharmacists all the time trying to show that they are relevant, whereas your perspective, it's much more meaningful to me, which is about the benefits as an entire team for the healthcare system and for patients. So thank you for that. And I'll now pass on to our following speaker. Dr. João Rafael Gonçalves holds a PhD in social pharmacy from an excellent university where I also work, so University of Lisbon. And the area of his PhD is exactly integrated care. He also did a master's degree in pharmaceutical sciences, so he's a pharmacist, and his experience lies in research areas related to medication use and interprofessional practices, with a special focus on social and clinical pharmacy fields. Since 2016, João has worked as a community pharmacist, gaining extensive experience in designing and implementing scientific and professional projects. And currently he serves as a professor of pharmacotherapy, pharmacology, and toxicology, and is also a senior researcher at the Institute for Evidence-Based Health. So João, the floor is yours. Thank you.
Thank you very much, Filipa. Thank you very much to my panel colleagues, to Cheryl, to Niamh. It's a pleasure to share this panel with you. Considering your background and your brilliant presentation that's touching many of the topics that I will bring with my presentation. And I would like to thank to the IFIC, in particular to Dr. Inês Nunes da Cunha, for accepting from the very beginning my proposal to address this topic in long-term care, because it's in fact for me a passion, and it's a passion that started a long time ago, not only for personal reasons, but mostly because I serve as community pharmacist, and many of of you know by experience that we deal on a daily basis with different patients, with caregivers, with other adults, and then and we need to integrate several skills and technical skills and knowledge. That's why I decided to study to undertake research in this field of research. I serve as well as you said, Filipa, at the Institute for Evidence-Based Health, which is a joint venture. It's a good example of the interdisciplinary work between physicians and pharmacists, because this is a joint venture between the Faculty of Pharmacy and the Faculty of Medicine of the University of Lisbon. And the main driver of this webinar is this professional group. I will address it in the end of my presentation, that I co-found and coordinate in collaboration with the Portuguese Pharmaceutical Society. I'll try to skip some topics that have been addressed by Cheryl and by Niamh, but I would like to, before dive into the core of my presentation, so the national ecosystem, the Portuguese ecosystem regarding long-term care and aged care, I would like to clarify, to distinguish some concepts, because I understand that depending on the country and the continent, the terms and the definitions related that gravitate around long-term care and aged care vary a lot. So I think it's important to understand the national case, and then we need to start from a bigger overview. Okay, so I like this definition by the OECD, the Organization for Economic Cooperation and Development, because it brings two important concepts: health and social. So healthcare and social care. And when we think about long-term care versus aged care, it's important to understand that the definition brings important topics, because long-term care is aimed to reduce, to manage health conditions, and provides medical and personal care with activities of daily living. And it's quite important to understand that it's targeted to people of any age with a degree of dependency. So dependency, more than a disease-centered approach, it's important to retain these concepts of dependency and support, social and healthcare support. When we look at the definition of aged care, by the term itself, it self-explains. We see that it's targeted to older people who need 24-hour functional support with activities of daily living, as well as in the same way as those receiving long-term care. But the big difference goes with the fact that aged care facilities or aged care, or the people receiving aged care, may or may not be staffed, the facilities, with healthcare professionals. So it does not function as an hospital ward and is not hospital-based. So we see that the healthcare has a bigger preponderance when we talk about long-term care rather than aged care. This slide may appear a bit dense, but as I told you in the beginning, there is a big amount of different terms and definitions referring to long-term care and aged care. As you may see, depending on the country, you may have different terms referring to long-term care facilities, to care homes, nursing homes, and as you may see, the definitions may vary. For instance, if you look at this definition, long-term care facility is a facility that provides medical assistance 24 hours per day with the activities of daily living. And when we look at the definition, for instance, of care home, we see that it's a facility that provides room and board as a long-term care facility to patients who are physically impaired. So typically, it's provided in a smaller home-like setting, and medical professionals are not available on site. Once again, the difference goes between the bigger preponderance between social support and healthcare support. So there is differences, as I've been trying to describe to you. The first one is the criterion based on age. Long-term care is based, or there is no cutoff regarding age. The needing assistance with activities of daily living are requiring both levels of care. But the big difference goes with these. So long-term care requires more skilled care, so requires a more qualified staff. Nonetheless, there is some features in common. So both focus on improving quality of life and well-being. Okay, despite, if you look at the likelihood for recovery, it's lower for aged care patients comparing with long-term care patients. The settings vary a lot, and the care can be delivered in inpatient, ambulatory, or home-based care, and often combine medical, personal, and social care. So as you may see, social care and health care are all the time combined, and we need a tight integration between these two concepts. In a national level, and after this brief overview, what do we have? The operational expression of long-term care in Portugal is delivered by the National Network of Integrated Long-Term Care. So integration is a pillar of our long-term care system. As I told you, long-term care can be delivered in inpatient, ambulatory, or domiciliary settings. And once again, age, as you may see, the National Network of Long-Term Care is also targeted to pediatric patients. So older adults are not exclusively the population that benefits from long-term care. The National Network of Long-Term Care aims or has this main goal, which is provide continuous integrated healthcare and social support to individuals of any age, again, in a state of dependency. So these two concepts are really, really important. As you may see on your left, the recipients, the population, the features of the LTC population in Portugal is not exclusively dedicated to older people. Of course, that older adults represent the majority of patients receiving LTC. But as you may see, we have two people under 65 years old. On your right, you have a brief definition of care home or residential aged care facility. As I told you, there is different terms referring to aged care. I brought this one. I decided to bring this one because usually, according to literature, are the most employed. So I try to use the most common. And in this case, for a care home is a residential structure for older people. Okay, that for many reasons, but mainly due to aging, are experiencing a loss of functionality. Usually, patients receiving aged care have a permanent loss of functionalities versus long-term care patients. You can imagine that if one of us has a car accident and after staying at the hospital goes to a long-term care facility, the likelihood to go back home is higher than 80 years old patient that goes to a care home and whose loss of functionality will decrease dramatically. And to sum up these differences, Portuguese differences, I was thinking about a picture that graphically could distinguish the two levels of care. So as you may see, there is much more residential aged care facilities in Portugal, which is natural because it requires a less qualified or skilled staff, comparing to long-term care facilities, which require, it's mandatory to have much more skilled staff like physicians and nurses. And I'm highlighting these details, the oxygen, because it's mandatory in long-term facilities to have oxygen therapy, which is not mandatory for residential aged care facilities or care homes. And I think this distinguish very well, clearly distinguishes the health and the social differences between the two levels of care. Well, once again, from a national perspective, because this is the core of this presentation, during my PhD, I met different colleagues, not only pharmacists, but also physicians, nurses, managers. I visited different long-term care facilities or care homes. And throughout this long and hard process, as many of you know, a PhD is a long and hard process. But throughout this process, I met or identified a set of opportunities that would lead or could lead to the development of a professional group. Before addressing and to close my presentation, before bring to you some outcomes from our professional group, I would like to highlight some evidence from my PhD. My PhD, it's about long-term care necessarily, so long-term care medicines and pharmacists, so a national opportunity to improve the delivery of care. The primary goal of this PhD was to characterize and assess, in the first place, medication usage. We are pharmacists, so our profession, I wouldn't say that gravitate around medicines, but our expertise is based on medicines, which is natural, and to characterize the pharmacist participation in inpatient units. So my field of study was inpatient units of the Portuguese National Network of Long-Term Care. This is a roadmap of the studies that support my PhD. I will not, of course, detail each study. You wouldn't have patience to hear me for so long. And I would bring to you some evidence that briefly describes the pharmacy practice in long-term care and aged care in Portugal. So I combine different approaches, so quantitative approaches, qualitative and mixed method approaches, and I will bring some main findings from these different studies. First of all, and Cheryl thank you, Cheryl, for bringing this diagram. This diagram, it was based on several of interviews that were undertook, or which participants were nurses, physicians, managers, scholars, so not pharmacists. And it was interesting for me to understand that in the first place, these healthcare professionals involved necessarily in LTC and aged care, they identify they state that pharmacists are crucial in delivering clinical pharmacy activities, in staff education, patient safety, and scientific research. And also interesting for me, they identify the underusing of medicine expertise by pharmacists, which is they stated that we pharmacists have, at least in Portugal, have more expertise to address medicines optimization than those that are being used. But on the other hand, they also identified some underqualification regarding clinical training. So this is an opportunity for many of us, in particular universities, to address this topic, clinical training, and also they noted that there is an absence of a legal framework establishing in a solid and clear way the activity of pharmacists, the participation of pharmacists in long-term care, in particular in the national network. From a more quantitative perspective, once again, this is a slide with many information. I would like to highlight just one or two features from these findings from this study. So we enrolled 3 different facilities, long-term care facilities. One facility was served by on site by one pharmacist working full time. The other 2 had no pharmacists. We have I would say a good representative sample of long-term care patients, and we compared 3 variables at admission and discharge. So we compared the number of medicines, the potentially inappropriate medication, and the exposure of patients to anticholinergic medicines or medicines with anticholinergic activity. It was interesting to find that the presence of a pharmacist contributed positively to reduce and to improve the number of medicines at discharge, and to improve the exposure of patients to anticholinergic medicines. It was with a small effective size. Of course, the study has some limitation, but through this study, we may see that, at least in Portugal, pharmacists, when present, can positively impact some important health outcomes. Now, from a qualitative perspective, in this case, from looking at pharmacists' perspectives, pharmacists' views, we see that we identify that pharmacists are concerned about the lack of time and pharmacists, so once again, human resources, which then limits the clinical pharmacy activities education. So if pharmacists are overwhelmed, are overloaded with extra work, so the time to deliver and to implement different clinical pharmacy activities is reduced. At the same time, and I would say that these 2 are linked, pharmacists do not work on site on a full-time manner. So they are serving different long-term care facilities as well, or at the same time that many physicians do the same, so different facilities, so the communication with the healthcare team is compromised. And pharmacists are also concerned, or at least identify the access to information, to social and clinical information as a barrier to better practice in terms of clinical pharmacy. Well, considering all this, and to wrap up my presentation, considering all these national-based evidence, this research, and adding to that some other topics, such as we pharmacists are among the most trusted professionals, not only in Portugal, but all over the world. Many organizations have been urging and warning countries for the shortage of healthcare professionals, and with aging, this demand for healthcare professionals will necessarily increase. In our case, in the Portuguese case, we have one of the highest shares of older populations, which is related with the shortage of healthcare professionals, and community pharmacies and community pharmacists, but pharmacists in general are well distributed in the country. So this is an opportunity. So considering all these, adding to the evidence already described, we identified an opportunity to increase and to expand the participation of pharmacists in long-term care and aged care. And if we think or bear in mind the concept of aging in place by the WHO, the Health Organization, and on top of these, the rising demand for long-term care and aged care, we, a group of 7 pharmacists with different backgrounds, working in different places in the country, proposed to the Portuguese Pharmaceutical Society the creation of a professional group dedicated to long-term care, palliative care, and geriatrics. We decided to combine different disciplines because you may find hard why did we brought together palliative care and geriatrics and long-term care, but we know that despite being separate disciplines, by not only from our own experience, professional experience, but also from evidence, from scientific evidence, we know that many times people assisted in long-term care facilities or aged care facilities need a more adjusted care regarding palliative care and geriatric care. Among other outcomes, because we have been working for the past two years, we have been answering to other colleagues that call us the group with questions. We have been commenting and assisting several official guidelines, official reports. So we have been working with different colleagues and different associations in an integrated way. But one of the main outcomes of our professional group, and it was important for us to, before developing activities, we needed to map what are the main concerns of pharmacists practicing in long-term care facilities and care homes. That's why we distributed and we developed this national survey, and we presented this poster last year. And among other things, we identified some themes, some topics that should be addressed and represent opportunities. Once again, lack of resources. Pharmacists are concerned or would like to be offered more targeted training, in particularly clinical training. Are concerned about the career, a legal framework that can establish in a more solid way our practice in long-term care. And to wrap up, I would like to leave to you some take-home message on behalf of our professional group. We know that aging and dependence are expected to are increasing. All the reports state that. We know that drug use, pharmacotherapy is widely employed in long-term care and aged care settings. We know that polypharmacy, in particularly inappropriate polypharmacy, is increasing, and for these, the opportunity to optimize prescribing is a reality. So, and we as pharmacists, we should step forward and optimizing in an integrated way, the interdisciplinary way to address this important topic. I always it's like a mantra to me. I always bear in mind that we pharmacists hold both clinical and social responsibilities. So we cannot look just at the medicine and optimizing pharmacotherapy. We have to look at, for instance, social determinants. We have to look at the patients. We need to care, and to care, it's a complex process that needs different professionals, different backgrounds, and we pharmacists sometimes may be a bit too focused on medicine. So we care through science and medicines, but the process of caring requires, of course, technical skills, knowledge. We know all that. Yet, and I would say this is the punchline, and this is once again what I keep bearing in mind, and when I talk with colleagues and with my students, we have to have, it's mandatory, I would say, a humanistic approach. We need integration, and we need interdisciplinary collaboration. Otherwise, we cannot deliver the best practices in long-term care and aged care. That's it. Thank you very much.
Thank you very much, João. This was very interesting also for participants to understand better the reality in a specific country. So I realize that many of you have been using the Q&A box, which is excellent. I would just like to remind the others to feel free to add your questions. And if you have any question that's directed at a specific speaker, feel free to mention it in your questions. So I'll just start and pick up some of the questions. We will not be able to address all of them, but our speakers will make sure that the remaining questions are answered in written, or eventually you can also reach out to them later through email. So I believe the first question we have here, and we have two that are kind of related, and I think are most suited for Cheryl, if possible. And the question is about the outcomes that are chosen in different studies. And there's a specific question on why do you think that pharmacists do not impact on mortality? But before answering that, also what happens if during medication review there's no change after the medication review in terms of the profile of high-risk medicines that the patient is taking. Maybe these two can be somehow answered together. Cheryl, if possible.
Yes, thank you. I think there's a couple of factors to consider. As researchers, we want to be strategic about outcomes that we're measuring. And that means that not every outcome is included in every study. So some things that are meaningful might not be practical, there might not be resources. So there's many outcomes that you can capture. But the research still informs us when there is something that is not statistically significant. So mortality is one where I think it's important to consider, was that a helpful or meaningful? Was that a meaningful outcome? So when we look at individuals in long-term care, in my setting, their life expectancy, I mentioned, was 18 months. And so we are dealing with people who are extremely frail, end of life. Most of the clinical practice guidelines for disease states do not apply. They're so much older or more complex that we can't just follow cardiovascular guidelines, for instance. And so what we are looking at is not the typical disease measures that you would see, like reducing mortality, but we are looking at more quality of life, humanistic measures. Are we supporting individuals so they feel well, they feel that they're not sedated, they're engaging in activities, it allows them to be functional, it allows them to interact with their family, it allows them to, the caregivers feel positive. And so the outcome of mortality, I'm not sure, given the short life expectancy, that we could possibly see that much benefit. I don't think it's wrong to measure in that as we look at things like deprescribing, we're stopping a lot of medications like cardiovascular medicines, endocrine medicines. We're reducing some of the burden in, say, diabetes or cardiovascular disease. But so we want to make sure we're not causing harm in those processes. But I'm not sure if I was designing a study now, I would include mortality as a primary outcome. I would monitor it more as a safety issue, that we're not causing harm that is leading to, say, by stopping statins, we're causing more strokes, allowing more strokes to happen, for instance. So I think the life expectancy is too short and it's not a priority, but humanistic measures like quality of life, how caregivers feel involved or how engaged the individual is in the activities at the facility are actually more important outcomes. So thinking about functional outcomes, I think should take priority in that situation. So I think that's why, just that at end of life, we are not going to extend life expectancy any further. I'm not sure if my other panel members have any other comments on that.
I agree with you, Cheryl. It's many times we think about those hard outcomes, isn't it? Instead of proxy, and we need to adjust what kind of according to the features of our populations. And I would say that probably we pharmacists, given the lack, depending on the country, of clinical training, we try to look more about mortality, falls. It's important, but we have to adjust, and we should bring more clinical and humanistic outcomes instead of those typical outcomes as mortality. But I totally agree with you. Yeah.
And I would add in the health economic evaluations we're involved with, it's healthy years of life lived that we're looking at. We're no longer looking at mortality, and given the population we're talking about, it's the healthy years of life lived and quality of life metrics that tell us far more about the impact of what we're doing. So completely agree.
Thank you. And the other bit of the question, maybe I wasn't so clear, but it was more about the process. So what happens, or what's your opinion? And perhaps I'll just lead it to all of you and not specifically for Cheryl. What happens when you do a medication review and then nothing changes?
Well, in my clinical practice, I can say I have experience with that, where sometimes we can't directly affect the change. We cannot stop the medication or start something or make a change. And you're hoping the team members are receptive and will help implement the change. Recognizing, for instance, if we're recommending a taper of something, it influences how now the team members have to be splitting the tablets or thinking about how that tapering is done. And now I've added complexity to my colleagues' work life as well. So for me, it has been sometimes it sounds discouraging, but sometimes when there's discussion, so I'm getting feedback, I'm having dialogue, I'm part of the team process, I can hear the rationale. And so, well, we had this concern from the family member, we had this concern from the spouse, the daughter, we had this other adverse event happen as we tried to deprescribe the benzodiazepine. And, we don't want that happening again. The patient really had some withdrawal effects. And so we're hesitant to do that. And so there is often context. People don't reject the ideas. I mean, there are some clinicians who are not that respectful of pharmacists, but for the most part in geriatrics, we generally see a team process. And I often find through dialogue, there's rationale. So there might be, that informs me, there might be education that I might have to do. Maybe I have to temper my recommendations a little bit and be a little bit more conservative or do things a little bit slower. I have to engage thinking about all of those touch points, not just that I'm talking with the physician who is the usual prescriber, but I'm thinking about the frontline staff, the healthcare aides, who are the ones who have to now figure out if someone has their antipsychotic discontinued and there's behaviors emerging, like what do they do? They're really the ones that take the brunt of some of those problems. And so thinking, I guess partly it's empathy, what my colleagues are going through, and understanding their rationale. So I think that has helped me not take it too personally when my recommendations are rejected. It's sometimes a marker for me that I need to do a little bit more homework as to what's happening in that situation.
I think what Cheryl has identified there is a really good example of how, by working in an interdisciplinary way, building new relationships with other people, including caregivers, you are actually then creating new interdisciplinary knowledge. So it goes beyond what you know as a clinician to something that's applied in practice and is genuinely new interdisciplinary knowledge. And that's one of the things that I think as knowledge sharing organizations, we probably need to get better at capturing as well, because I'm not sure that we do that as systematically as we can do. And that's one of the things we try to do at the International Journal of Integrated Care, is try and capture integrated care case studies that capture that new interdisciplinary knowledge that's emerging out of practice that we're just not doing through other forms of research at the moment.
I would like to add just a recent conversation I had with a GP. He's over 40 years of experience, and he serves in a care home. And of course, he has patients with polypharmacy. And he was talking to me, and he is a respected person. He's 70 something, 74, 72 years old. And he was saying to me, João, you know, sometimes I want to de-prescribe some medicines, but in the first place, the patient doesn't want it, or the caregiver, because they told me, oh, this medicine was prescribed 30 years ago by a professor. So trust it's a process, and empathy, it's a process really, really important, not only when we health professionals interact with caregivers and patients, but in the first place, when we, the healthcare professionals, interact with the prescriber, that can be a pharmacist, a physician, a nurse. And it's important, I know it's a bit vague, but empathy and as Niamh brought this important difference between multidisciplinary and interdisciplinary, and it's really important. I think that to avoid like prescribing cascades, for instance, and I totally agree with you.
All right, thank you. Let's move on to another topic, which perhaps Niamh can start at least, which is about how to set up integrated care, how to start. You've given some good examples from Flanders and from Ireland. We have a participant here who is particularly interested in how NGOs fit into this map. Where can they fit? And specifically, he's talking about heart care, but I think that's just a minor detail. It's more about having your advice on what's the most important features to start with.
So I think integrated care, and I think the main thing to say is that people are using different terms often to describe what we would talk about as integrated care. So good examples are a lot of the work that WHO are doing around primary care and the development of primary care in different countries. Also the work I mentioned, the WHO work on aging, age-friendly communities and cities. A lot of that would be what we would exemplify as great examples of integrated care. So whilst we talk about integrated care as an umbrella term, there are lots of different ways of talking about it. I think it is already happening in many countries. I think the first thing I would always say is, what is the purpose? What problem are you trying to solve that integrated care you think is going to address? And in many cases, it has historically been a response to the demographic shifts that we're seeing in our society. So we started our movement, if you like, in the context of aging and recognizing that our populations with complex presentations, multiple morbidities, were going to present a different set of challenges to our health and care systems than we had previously experienced. And it's really an attempt to redesign, to challenge policymakers to think about how we can make our health and care systems fit for purpose for the future. So I think that is always my suggested starting point. It has to be about having conversations with policymakers and with senior leaders around how taking an approach to integration and community-centeredness can actually help to address the very fundamental problems that every single health and care system is facing today, which is how do we redesign our health and care systems to deliver for people living longer, but people living with possibly less health than we would like, certainly in the last decade or two of their lives. And integrating health and social care is really, you know, to me, it seems like a very obvious answer. And I appreciate that it's less obvious to some people than it is to me. But given the amount of what we know happens in terms of duplication, but also clinical risk, and medication errors are a really good example. And it mystifies me that we still haven't really addressed the extent to which medication errors are a source of clinical risk and waste in our health and care systems. And this really could be such a quick win for integrated care models.
Thank you. Perhaps here I will just move on to the next topic without wanting to cut unless you have some burning comment, Cheryl and Joel. But I think there's also a very important issue that's being brought by participants that it would be good to have all of your comments, which is about the workforce shortages that all of you somehow have mentioned, and how what are the solutions here, really? There are some participants coming from low and middle income countries, which they talk mostly about not having enough nurses, but surely there are in other countries not enough GPs, in others not enough pharmacists. And I think it was Niamh who mentioned about the approach from WHO of having like a skill mix and from passing some of the responsibilities from one professional to the other, but also alongside with education. And there's also a specific question, I think, intended for João about the role of education in all these countries where these transitions are happening. What are the things that are being offered to make sure that professionals are competent to deliver regardless of their basic education? So maybe Cheryl, you can start.
Well, I'll give a few examples of challenges we're having. So in pharmacy, I'm involved in pharmacy education. I work at a faculty, and it is challenging enough just to get geriatrics into the curriculum agenda, and then to discuss long-term care as another step in working with geriatric. In Canada, almost all long-term care is geriatrics. It's not younger age groups necessarily. And so we have kind of a battle with ageism, and geriatrics, rarely do we see cures for things. And yet in other specialties, people are drawn to the algorithms, the pharmacists like algorithms and process and resolving problems, right? Even though we deal with chronic disease, it's very challenging. There's something in our mind that just wants something to resolve. And so I think we're in a bit of an uphill battle, but making it, I think we've seen and done some interviews with other experts that sharing some of the rewards and the interest in how all of our expertise is really brought in when we are thinking about the complexity. So it's not acute in most cases. Like acute is, we'd use the term kind of sexy, like the ER shows, like there's reality shows or there's dramas about emergency departments, and yet there's not really a drama about long-term care because things happen kind of slowly, right? And so but sharing about how, it really is demanding. It really is rewarding when you don't necessarily cure something, but you do make it better. And people, the residents and the family are pleased, the staff are pleased. Like that is a success. So I think sometimes instead of thinking about cure and fixing and resolving drug therapy problems, thinking about how we are improving life, improving well-being for these residents. And so sharing some of that, I think, makes some touch points for our students. Thinking about that as a career path is important. And then again, showcasing this as well with our continuing education for pharmacists. I'll point out some of our challenges in Canada relate to an intersection as well with some of our frontline staff. We have a lot of people who were born outside of Canada that are providing some of the frontline care. So there's stressors for them in terms of crossing cultures with providing care for people, and some of the preparation there as well. So I think we're sometimes not preparing our workforce as well. It's not just about these are the steps to transfer someone into a wheelchair. These are the steps for administering medications. It's the how do you function in this really complex place where there's a lot of different people with different backgrounds. So a lot of nuance as well.
Cheryl, maybe.
Okay. Well, if you are referring to undergrad and depending on the level, I mean, if you are referring to the education of pharmacists, I believe that we need to more clinical training. We need to clinical reasoning in the first place. And when we are talking about the practice in the field, I would say that we as pharmacists we need to have the chance to more seamless, more easier interact with other professionals. I have many cases in the pharmacy. Like 10 years ago, I was working as a junior pharmacist, and I noticed in one patient that she was not okay. I mean, in terms of cognitive impairments, and in the meantime, she had 2 appointments in the GP, and everything was okay. And I reached out to her son, and in fact, she had a dementia because every time she was going to the GP, everything is okay, but the constant contact with the patient led me to understand, led me to notice some impairments that she was suffering, and it was in fact a dementia. So I believe that we, depending on the country, it's hard for me to address this topic because there is different roles and responsibilities of pharmacists and other professionals. It varies a lot, but I would say that expanded roles, in particular pharmacists, could be a solution because the pharmacists, in particular, of course, I'm biased, but we, the community pharmacists, we see patients on a daily basis almost. And I'm not referring only about clinical purposes, but also social purposes like abuse, many, you know, the topics I'm referring to. So I think that it would be beneficial both for the system in economical terms, but also in improving the quality of care if the pharmacists or the nurses could have their roles and at the same time responsibilities expanded. I think it would be beneficial, and I think that patients would be thankful too.
Thanks, Niamh. Can I ask you to be brief? Niamh?
Sure. So just in terms of final thoughts, I would just remind us all that long-term care is not solely residential. Increasingly, long-term care happens in a person's home and in their community. So when we're thinking about models of integrated long-term care, we're remembering that long-term care is in fact most of the time now happening in people's homes and in people's communities. So that it makes integration even more important.
Thank you very much. I would just like to highlight that Cheryl just shared a useful resource for those of you that want to know more. Unfortunately, we are running out of time, so we will need to pass on to the closing. So I would just like to remember the participants that the recording of this episode will be available at the website, so www.fip.org. And please make sure you provide your feedback to webinars@fip.org so that FIP may continue to improve their digital event offerings. And of course, you can visit the website for all future events. I would also like to mention that the recordings of the first 2 webinars in this series are also available on the website. And before we end this session, let me just tell you that the next year's FIP Congress will be hosted in Montreal, Canada, under the theme One Health, One Pharmacy, Bridging Science, Practice and Education. And the Congress will be supported by the Canadian Pharmacists Association. There are 3 main themes, which you can see here on the slide. And as any other Congress, there will be very interesting sessions for all areas of pharmacy. So thank you all for participating. I would like to thank the interest of the audience to stay on board until the end and making so many questions. And of course, I would like to thank our fabulous panel of speakers for sharing their expertise and experiences and knowledge. Thank you all.